Chapter 36, The Infant and Family, Sandra Monk. Promoting optimal growth and development as far as biological development and proportional changes. There's very dramatic changes in physical development and growth during the first year of life in infancy, probably more than any other time in the human's life. Growth occurs in spurts instead of steady, sustained growth. Um, as far as proportional changes, the big concept here to remember is that the infant will double their birth weight by age 6 months by gaining 5 to 7 ounces of weight a week, and triple in birth by age 1 year. They will double in weight by 6 months and triple in weight by 1 year. And yes, I said that 2 times because that's very important. You'll be pulling on that kind of information as far as conceptual knowledge when you're in clinical and also for examinations. Their growth will occur as far as height in spurts rather than in a gradual pattern, and weight as far as that's concerned too. The maturation of systems. Their systems continue for the first really 6 years. First 1 year, there's a lot of maturation that continues, but even up to age 6, different parts. We'll talk about those as we go through the different developmental stages. Kids are prone to more respiratory infections during this time because their abdomen and their chest are in very close proximity, and so puts the trachea and the bronchi, close to, the GI tract, and so they get infections that way. They have very short, straight eustachian tubes, and so they can get infections from their pharynx. And also, they have less developed immunities. Full-term kids have pretty good immunities, but preterm kids have less, and then their immune system is not completely developed until they're, in early childhood. Cardiovascular continues to develop, so you see rapid respirations and a higher heart rate, and so forth, and then they continue with changes from fetal circulation into their normal human cardiac functions. Hematopoietic changes in their blood system. One big thing, and you'll see this when you're evaluating your labs for in clinical, around ages 3 to 6 months, kids get a physiological anemia due to fetal hemoglobin iron changing, and it causes them to have a drop in their hemoglobin and hematocrit. So you'll see that if you take care of an infant, and so iron stores change and so forth. And so, like preterm kids, you may see them getting some iron. Digestive processes. Their kids are unable to process complex carbs like peas, carrots, corn, raisins, and peas, and so you'll see these kind of things like pass through their stool unchanged. So when kids first start getting introduced to these sort of more solid foods towards the end of infancy, you'll think there's something wrong with the digestive tract, but there's really not. It's really a more of a problem with they just can't digest. And then so they can't really digest, so they'll pass through their stool unchanged. All right, and so small frequent feedings are something that these children have because their digestive system are not fully developed, and so kids need 3 meals, so like 3 bottles and an evening bottle for the first 1 year, and that's all about that. Okay, next slide is fine motor development. Okay, and so kids have begin grasping objects at ages 2 to 3 months, and it's sort of something that is more kind of just kind of instinct, and then they begin to realize that they can do that, and so they begin to trust they can do that and develop that. So that reflex eventually becomes voluntary, and like parents will see them like grasp a hold of their finger or a rattle. They can just like instinctively hold on to it. By age 4 months, 4 or 5 months, they begin to be able to voluntarily grasp an object, and you'll see kids like pull things off of pull things off of the table by 5 months. Their parents didn't expect it. It's like the first time they did it. And then they can transfer object between hands at age 7 months. They have pincher grasp at age 10 months. They remove objects from a container by 11 months and build a tower of 2 blocks by 12 months. You'll see when you do your Denvers that this varies, and so it doesn't mean that, a child has developmental lag unless it's like many months, that goes that, between developmental milestones being met. Next slide is maturation of systems. As far as maturation of systems, they do not have the ability to maintain thermoregulation. Their ability to respond to heat and cold because their capillaries do not adapt. They are more susceptible to changes in heat and cold and problems that might occur from that. As far as renal function, they have a good or the very best that's going to be in their life when a baby is young, and then it of course changes and continues to gradually decline until people are in their older adult ages and they have some really reduced renal function. Sometimes that can be accelerated by disease process. But sensory, the hearing is the same as an adult from birth, but vision continues to develop. They have binocular vision from 6 weeks to 4 months, depth vision by 7 to 9 months, and that's why we really have to make sure with safety that we make sure that they like when they're crawling, creeping and crawling, because it's that is like a safety mechanism that we have our depth perception against falling. And this next slide is a picture of a baby with a crude pincher grasp at age 8 to 10 months. And then as far as gross motor development, it takes them a while to gain head control. That's why we have to protect the head of a very young infant because they can't, they don't have any control at all. So we need to make sure. And sometimes you see kids like in the nursery that, their head, they seem to be able to hold their head up and seem very strong. But, this still is, something that has to be maintained, has to be gained, and then, they continue to develop with. They begin to roll over by age 5 or 6 months, and sometimes you'll see kids 1 or 2 months that can roll over, and that's just because of a balance issue. They get all wound up, maybe crying or something, and they raise up, and because their head's heavier and their torso, then they'll flip over. So really, it's good to guard. If you think you've laid a baby down somewhere and they're only 1 or 2 months old and they can't turn over on a scale, wrong. They definitely can. Some kids start sitting up as early as age 7 months. But that usually is can vary to 8 months. They can move from prone to sitting position by age 10 months. And the next slide shows some of the head control while being pulled to a sitting position at 1 month. They've got complete head lag, at partial head lag at 2 months, and almost no head lag by 4 months. So it tells us that we really need to protect the head of kids under the age of 4 months. Here's head control while prone. Just kind of shows you how they can momentarily lift their head at 1 month, and that is when these kids can, when they lift their head like that, is when they can actually roll over. And this is the point that by 6 months in C, you can see how they can push up and bear weight on their hands. Here's the parachute reflex, and you need to review your reflexes. Here's the development of sitting. They have no ability to sit at 1 month. By 2 months, they have a little more control. You can see that baby's actually starting to pull up. If they were going for their well checks on a monthly basis, that would be what you would see. And then they begin to get rounded, but begin to be able to get up a little bit more at age 4 months. Then they can sit alone at 7 months with some support. You need to be leaning on some hands for support, but they start to be able to. And then by 8 months, they can start to sit without support. And then E shows that. Notice that this kid is transferring objects between their hands at this age. Locomotion, remember what we said, cephalocaudal, sequential, type of growth and development. They begin crawling by ages 6 to 7 months. They begin creeping age around 9 months, although that can be 8 months or 10 months. Walk with assistance at 11 months and walk alone at 12 months. Developmental locomotion, the infant bears full weight on their feet by 7 months, and then they can maneuver from sitting to kneeling. And then they begin to hold on to furniture around 9 months and walk around a little bit. And then they take deliberate steps at 10 months. And then they can crawl on their abdomen on the floor and pull their stuff forward and then begin creeping on their hands and knees. So it's a process. Erikson, you'll need to know this, and there is an article that's in D2L that's called about growth and development baby, and it's all about Erikson's distinct stages for growth and development. So you'll want to review that, and that'll be discussed also in clinical. And this is where the child is acquiring a sense of trust while overcoming a sense of distrust. And so this is learned in a child. Just like the attachment we're going to talk about, that's a learned process. And so delayed gratification leads to mistrust, like children that are allowed to just, cry with no answer, then they can become, can affect them cognitively. So from birth to 1 year is trust versus mistrust. And it begins with food intake. It's one of the most important ways that kids socially interact. And there is a total concern for self at this age, and then they begin the next part of their development through grasping versus reflex, but then it results in pleasure for the parent and the child, which helps with that bonding, and then it also creates trust. And then a more active phase later in infancy where they begin to bite things. They learn they can bite and hang on, and that sometimes happens during when a mother is nursing the child, which has to be remedied. Let the child know that they can't do that, but they can still breastfeed. Piaget is sensory motor phase, birth to 1 month, reflex stage, reflexes of crying, rooting, grasping, and sucking. 1 to 4 months, he talked about the primary circular reactions that replaces reflex with deliberate acts. They can actually stop crying when they hear the parent's voice if they're hungry. Ages 4 to 6 months, they have secondary circular reactions like banging, shaking, or pulling to elicit a response, like pulling on the parent's clothes, shaking. They'll bang a toy and see if they can get some response from somebody. Imitation is the second half of the first year where they begin to imitate sounds and simple gestures to the point that they, do patty cake and, follow, certain things. And play is brings them pleasure with sensory motor type of play. And as far as affect, there are outward manifestations of emotions and feelings even during infancy. And then there's a concept of object permanence, and I'll show you a picture. The next slide will be that. But by the end of the first year, they begin to recognize that they're distinct from their parents, and they'll actively search for an object hidden behind a pillow. That's because the baby knows that is, that is something that they have learned. Is one of the first things that they learn, because that helps them to identify that they are separate from their mother, and that they are attached but separate from their mother, attached emotionally but separate from their mother physically. Here's a 9-month-old enjoying their own image in a mirror. Other types of other concepts about their social development would be related to attachment. Children begin to attach with their parent or other important other. Caregiver first. I mean, by the time a baby is just a few weeks old, they are more attached to their mother. There's like two important ways that this helps with their cognitive development. It's the ability to discriminate the mother from others, and the attachment of object permanence, which we just looked at. But children will first attach to somebody. And different things that happen is they are more often to cry, smile, and vocalize to the mother than anyone else, or who the person that they're primarily attached to. And they'll look at their mother more, even if she's not close. They'll be looking for her, and they'll cry when the mother leaves the room, and they will actually approach the mother, crawl towards the mother in the room, and especially in the presence of a stranger. And they will begin, kids eventually over time in infancy, they'll move, as they begin walking and creeping, they'll move further away from the mother, but you'll see them, still like making sure she's still there, and checking in on that. Okay, reactive attachment disorder is caused when that attachment does not occur, and it can cause children to have some real social problems, and even become, destructive, poor impulse control, destructive to self and others. And so there really needs to be early intervention if this is something that the child is going through. Sometimes kids with bad behavior, it's not, their fault. Either limits have not been set, or they have some other type of behavioral or cognitive or physical problem going on. Separation anxiety can begin as early as age 4 to 8 months and goes through the first stages. By 11 or 12 months, they have this well developed, and they can even begin to anticipate. They see mom getting her purse together to go to work, and they begin with their getting more irritable and knowing that this separation is about to occur. Then they can have stranger fear, where they demonstrate attachment to one person, and they have less friendliness for other people. This is like between ages 6 and 8 months, and that's why we don't like get in a baby's face and try to get them to you know respond to us, because it can be very scary to them. Language development, they learn that from initially crying is their first way that they can communicate to us through displeasure, like for hunger, wet diaper. But the first few weeks of life, it is really kind of reflexive, and it's related to a physiological need. Kids need to cry some, not that you let them cry, but this is just something that they need to do, and it tends to decrease by age 12 months. The problem with this is, like, if you have a mom with postpartum depression and a child that's crying a lot, that needs to be picked up on right away, because those two things don't necessarily go together, and that mom is going to need extra support in order to be able to maintain a good relationship with her infant. But eventually that crying becomes syllables and words, like mama will be heard, or da da ah sort of sounds that kids tend to make. And by the ages of 9 to 10 months, they begin to comprehend the meaning of the word no and to obey simple commands. And by age 1 year, they can say 3 to 5 words. With meaning. So they can smile by ages 2 months, squeal by 3 months, laugh and have favorite toys at 4 months. 6 months, refuse to play with strangers. 7 months, cough or squeal, if let somebody know that they're in the room. And at 10 months, they'll begin to pull on their parents' clothes, just kind of to respond and to socially respond to them. And by 12 months, they're able to call you can call them by name. Behaviors related to fear of strangers includes clinging to the parent and turning away from the stranger. It's very obvious. You will see it in clinical. Revised Infant Temperament Questionnaire looks at sleeping, feeding, dressing, diapering patterns, playing patterns. You want to avoid using the word difficult child when you talk about temperament with families, and use intense or less predictable child. Child rearing practices are related to temperament, so those need to, the parent needs to understand every child's different, and you got to respond to every child different. Difficult child responds better to routine. They need structured bedtimes, more soothing methods such as rocking. It says backpacks here, but I believe that's back pats. If a child has high energy, they need extra precautions and room to play. If they are slow to warm up kid, they need a gradual preparation for new situations. And an easy child, they might need to be awakened and fed on regular intervals. Particularly if there's other kids in the home that are intense and less predictable, or this could be, first child, that the parents, think they're waiting for the kid to start crying to feed them, and they actually would need to wake this kid up, because they probably are not going to, make a big fuss if they're hungry. I mean, they eventually will, but they, may cause them to actually, lose weight and not have adequate nutrition. Separation and stranger fear. You should talk softly to the child at eye level. Um, Alternative child care arrangements is another concern, because parents kind of they get concerned with with child care arrangements. So in-home or small family centers work very well. Sometimes they're work-based centers. Certainly many kids have lead successful adult lives who were in child care centers while their mother worked. It becomes an issue with sick child care, so you need to remind parents that they will need to have a backup for their backup for sick kids. And it's difficult to find credible babysitters, and you need to look into all of their different credentials. Look at child care centers, see if there's been any complaints against the child care center. Look at what their ratings are and what their reports are through Department of Family and Children, through the state. There needs to be limit setting and discipline with children. we'll talk about some of those things like with sleeping disorders and so forth. Thumb sucking and use of the pacifier. They're, non-nutritive sucking. There's some debate about that. The research has shown that it does prevent SIDS deaths, so that's not an altogether bad thing. And also, some children come out of utero. I mean, they're born thumb sucking. Non-nutritive sucking using the pacifier is also used, like little sugar water with a child that's going to have, a procedure or something like that. But using the pacifier, like some parents, you see them like forcing it on them. It's like, don't you want your pacifier? For any time that they begin to fuss a little bit, and so that sometimes can be difficult to get the pacifier away if they get into a habit with that. And there's not really any reason for it, except for those two reasons that we talked about as far as research is now. Of course, that all changes. And then there is teething. This is something that parents, it can be a very difficult time during the life of the parent and the child, particularly the parents, because it can be a lot of crying and biting and fussing, going on with the child. Um, and so it just needs to be addressed. There's going to be some discomfort as that tooth breaks through the periodontal membrane. Some kids will be drooling, increased finger sucking, or biting on hard objects. Some of them will refuse to sleep or eat. And generally signs of things like fever, vomiting, and diarrhea, they really are not signs of teething. And some parents will go, oh, they're just teething, and they've got some kind of viral thing going on, and they're bringing them to the child care center with diarrhea, and they've actually got something going on. But chewing on a frozen teething ring can help. There's ointments such as baby Orajel, but really they shouldn't use a lot of that, because that can be taken, can become systemic. So that needs to be used with very much caution. There are some parents who will actually, help the tooth through, or have them chew on something, or putting teething powders on. Those really are not recommended, or rubbing the gums with aspirin, but you'll get a lot of advice from grandparents sometimes. Infant shoes, they don't really need any kind of special infant shoes, just some kind of soft sole shoes. Usually they can begin wearing shoes about age 6 months, and before they're walking, but they don't really need to wear shoes. They just need a good soft walking shoe, kind of like inexpensive sneakers, or just like we would wear. First 6 months of life, breastfeed milk should be the only food. That's the recommendation. That is the best source of food for baby. But of course, some people choose not to, for whatever reason. They choose not to breastfeed, and that's definitely is a choice. But that is considered the best choice. It's the most desirable diet for infant during the first 6 months. And from a well-nourished mother, they should get everything that they need. The second 6 months, you can begin to introduce preparations of solid foods, and that's one of the topics that y'all are going to work on. So I look forward to seeing what you're going to say about that. Breast milk should never be warmed in the microwave, because it destroys vitamin C and other infective type properties that it has in there, causes the milk to separate, which affects the fat content. So that is not good. And also, if you're heating either formula or milk in the microwave, it can unevenly heat, and it can be a burn problem. So breast milk should be thawed. If the mother pumps, it should should not be rewarmed in the microwave. It should be put in a container of lukewarm water, and allow it to come to room temperature. And milk doesn't really need to be, unless it's ice cold, it really doesn't need to be heated a whole lot. Kids can take milk at at room temperature. So so the amount of food that kids should take, it kind of varies. It's usually on a demand feeding, but they really should, you know, uh, have like 4 or 5 feedings a day when they're, before age 6 months, and then gradually up to age 12 months, like four servings, and maybe a nighttime uh, bottle to go with that. But that's going to vary per kid. It's going to vary by what the pediatrician says. Infants are naturally active. They are naturally getting into trouble, so they have to be watched all the time. Walkers, swings, and playpens are not necessary, and sometimes can actually end up being, a type of a danger. Um, and then there are sleep problems. There are kids who refuse to go to bed. Not refuse, but yeah, I guess refusal to go to sleep. I guess they just have a whole lot of things to do, and will. Um, and so it's hard for them to get to sleep at night. Nighttime fears. There's actually with infants, those other things I think we can talk about in some of the other ages, but some kids, just kind of wake up in the middle of the night and crawl a bit, and go back to sleep. They need to be reassured. You don't really need to get them out of the bed and put them in the bed with you, though some people, will, kind of do that. Um, and so the concept of graduated extinction is you need to help set limits for the child that, cries and has to, get up during the night. One thing parents can do is to, go in, reassure the child, and when they're crying, and then gradually back out of that, and the child will become used to that. They'll either become used to you coming in there and getting them and sitting there and rocking them for an hour and then putting them back in the bed, and then they wake up as soon as you put them back in the bed, so because they're training you that they want to be held during the night and while you're trying to sleep. And so that is one plan for that. I mean, of course, you'd never let a child just cry and cry and cry. You need to go in there and go to them and help them, comfort them, and then let them go back to sleep. One thing that's recommended is to not put a child into bed or put an infant into bed while they're asleep. Not rock them till they're asleep and then put them down, because then they realize that they've been tricked, and so they wake up crying. And so before they go to sleep, to realize that we go get in the bed and go to sleep. Although it's very sweet and very fun to rock a baby to sleep. Maternal dental health. Uh, Cleaning. The mothers have to help with the cleaning of children's teeth. This is from the time they first erupt. They need to have fluoride by ages of 6 months. So if they're breastfeeding, that would need to be talked about that with your with the pediatrician, and see what the recommendation is there. Um, and then prevention of dental caries. Of course, that is brushing of a child's teeth. And there's one picture either in this PowerPoint or another one that shows, how to hold a child to brush their teeth. And this next slide looks at how teeth erupt. When teeth, usually between 6 and 10 months is when the first front teeth begin to erupt. Sometimes they'll, like erupt on either side, like particularly if they're coming in late, like around 10 months, they'll get like their incisors in first. The side ones look like little vampires, and then the other ones will come in the middle. So that is just a list. Their picture shows the when teeth, but generally they start cutting teeth about age 6 months. Schedule for immunization. We're going to talk about this more. They do have to have routine immunizations for Hep A, B, diphtheria, tetanus, pertussis, and polio. And we're going to talk about that communicable disease, and these as well. We'll talk about communicable disease. Recommendation for selected immunizations. Yeah, we'll just talk about all that in the communicable disease one. Okay, safety and injury prevention, really big in peds, really big in infancy. Aspiration of foreign objects. I mean, that we talked about, that's what you spend a lot of your day doing when you've got, so things that can be aspirated, or anything that is not anything that is small enough to put in a child's mouth and swallow. They certainly will try and do that. But like a cracked rattle could have little beads in it, or stuffed animals, they can pull out a piece which would really obstruct an airway. Babies, because they can begin to grasp at age 5 months, could yank down that mobile and get some piece off of that, because mobiles usually are not things. Any small article, kids are going to pick up anything and put it in their mouth. Pennies, batteries, anything that they can get into their mouth, they definitely will try to do that. And food items, some food items like hot dogs, candies, nuts, grapes, any of those sort of things. Anytime that new foods are introduced like that, that you need to think about how you're going to give those. And hard candies are just not appropriate. Peanut butter is not appropriate for, a large amount of peanut is not appropriate for, or anything with a pit or a seed, because they'll just swallow the seed. They'll swallow the peach pit. You let them chew on a peach and then they'll swallow the peach pit. So pacifiers can be dangerous also for that. Um, and let's see, like syringe feeding is not a good idea. People will, try to feed their babies with syringes full of cereal. I know years ago that used to be kind of a common practice, and so that may be a holdover from grandparents, but that is not, really good there. Suffocation in the bed or crib. If they are put in tucked under blankets and sheets, they can get caught under them and not be able to wiggle free from there. They don't really need a baby pillow. Um, and like the boppies, they don't like to, use those sort of things anymore. Um, Mattresses and bumper pads need to be way away from the baby and snugly against the slats. And you just need to keep checking and making sure, all the time, like playpens, can they get up underneath the playpen and suffocate? Can they get into underneath the, all those kind of things need to be looked at all the time. Plastic bags, cords from draperies are very dangerous, and I think there's a warning on them now. Bibs worn at bedtime. Particularly if the kid starts drooling because they're teething or something. Some parents may put bibs on them and put them to bed, trying to keep their clothes dry, trying to be good to the child, make sure they don't wake up cold. But that can be very dangerous for suffocation if they get it too tightly around their neck. Any toys that have strings or anything on them, those can be dangerous. Falls, of course, watch rolling over, poisoning, burns, drowning. A child can drown even in a very small amount of water, and so that needs to be there needs to be caution with that. Electrical wires and those sort of things. Federally approved rear-facing infant car seat restraint up to 20 pounds. Here's some safety devices. Difficulties, regurgitation and spitting up can be an issue in infancy. And this is if there's just a little bit of spitting up, is kind of like drooling, a little bit of unswallowed formula, immediately after eating. And colic and regurgitation are two different things. Regurgitation is like large amounts of projectile um, contents of the stomach accompanied by burping, and so that's regurgitation. Spitting up is just kind of drooling out the unswallowed formula immediately from the mouth. Um, Colic is like paroxysmal type of abdominal pain, and it is very difficult to solve and to go through. Um, there's lots of reasons why kids have that, but the immediate fix is not a good one. It's really just kind of, it's not really any, don't really know, there's not really any gender, race, socioeconomic status, why kids have this, and they'll cry real loud and draw their legs up, and they could cry like 3 hours a day up to 3 days a week. With increased fussiness and crying. A lot of times it's in the evening more than any other time. It's more common in infants under age 3 months, so parents can kind of live through it. And also it's the kids who have the more difficult temperaments who tend to be colicky, and I can attest to that. Also, sometimes kids like maybe a cow milk allergy or intolerance, and just if the cow milk is or they're put on a non-lactose formula that could help, but they need to look into it and see what the problem of it is. And kids can be put on certain formula. Some of it's kind of very expensive, um, uh, like the extensively hydrolyzed type formulas like Nutrimogen or Progestamil. They can be, or soy formulas usually are avoided. um, and kids that are breastfed, they can be given lactobacillus and kind of see if that will help, with some of their, digestive distress, if indeed that's what's calling it. But mostly it's just, areas should be stressed include, consistent diet, kind of look at the time of day that the child is crying, just to kind of figure out, maybe troubleshoot and see if there's some things that can happen, so you don't just have to live through it. And again, this is one of those things that's going to be on the discussion board. And the next slide is a mama doing the colic hold. And there is consistent nursing contact is important in developing trust in infants with failure to thrive, because sometimes the parents, for whatever reason, are not able to do that. Sudden infant death syndrome, or SIDS, something that's a really important concept. We don't really know what causes it. It could be some type of brainstem abnormality, or a child that's experiencing periods of apnea. They have linked it with maternal smoking and co-sleeping and soft bedding, because the child, because everything is so close to their face, they're doing this constant CO2 breathing, which turns off their drive, changes their to respiratory acidosis, and they stop breathing. And so what they have found is like a pacifier use and a back to sleep program and a good firm mattress. The back to sleep program is that children are put to sleep on their back, not in a prone position, because that is definitely one of in autopsies they have proved that children were in prone position. Maybe that's the way the parents found them. It is a very difficult thing for a parent who has experienced that, and requires a lot of, a lot of compassion and a lot of work with the parents who have experienced a death from SIDS. And then when the parent returns home, it can be a really emotional time too. Some kids will develop an oblique or asymmetric head from sleeping on their back all the time, and if that happens, then they can be fitted with a little skull, helmet to help correct that. Okay. And then apnea or other apparent life-threatening events. Apnea is an unexplained respiratory pause of 20 seconds or more. And some kids, because their respiratory system is not fully developed, because they may be aspirated a little bit because the proximity of the trachea and bronchi to the stomach. So it's really, but usually mostly unexplained at all. And some of these apnea and apparent life-threatening events, they want to diagnose it. I mean, the parents will report this, and you'll see a lot of kids in the hospital on a monitor, and that's just what they're trying to do, just trying to evaluate what is going on with this kid. Some therapeutic management is to give them theophylline or caffeine to keep them stimulated, to have them on a home apnea monitor, of course, then family support and CPR training as well. And here's one of the monitors. When we have kids, of course, the monitors will be on the wall, but the little babies may have, small infants may have the electrode placement for the apnea monitor. You see where that goes, and hopefully we'll be able to do some of that in the lab, so you can kind of see what that looks like, so you won't be frightened when you go into clinical. There's the back to sleep program. There's the Plagia Valley, and that is the end of this discussion.